So just really quickly, just to introduce ourselves, I am Amanda Consigli, and I am the public health analyst for the overdose response strategy here in Massachusetts, and I work for the New England HIDTA. And our positions are embedded within the Mass State Police Fusion Center. And I've been with the program for just over a year now, which is really exciting. But prior to joining Jim and the ORS team here in Mass, I did a lot of work in HIV and STI prevention. So that's kind of the world I came in prior to joining. And I am, by training, I am an epidemiologist, and I have a master's in public health in epidemiology and global health. So I'm going to switch it over to Jim for him to introduce himself and take it away.
Good morning, everybody, and thank you, Joe, for that introduction. We really appreciate the opportunity to be here and speak to you all this morning. We do these types of presentations around the Commonwealth. We're the overdose response strategy team for Massachusetts, and as as we go on in the presentation, you'll find out that the overdose response strategy is actually a nationwide program, so the people doing our job in basically all 50 states at this point. As the district attorney mentioned, COVID has changed everything. We would really appreciate being in person with you all in a room and having a cup of coffee and talking about this as opposed to over the Zoom. And hopefully that'll happen again really soon because you lose that personal interaction with people, and we really kind of thrive on that. But this is the next best thing for now, and hopefully the vaccines will be moving out quickly for all of us. So hope is on the horizon. So. My background is in law enforcement. I spent 33 years with the Town of Reading Police Department. I was the chief of police there for 11 years before I retired 5 years ago. Upon my retirement, I was fortunate enough to have come across the opportunity on this program, which was a fledgling program at 5 years ago. It was just beginning. I've been in this role now since then, and it's really been a great opportunity to see the overdose response strategy program flourish and become a nationwide program, and be able to work with the CDC Foundation, the public health analysts, and try to have an impact on the overdose. It started as the heroin response strategy, interesting enough, then went to the opioid response strategy, and now it's the overdose response strategy. But to have an impact on the overdose dilemma, the overdose epidemic that we're experiencing, as the DA mentioned, 80,000 deaths last year. I mean, there's a lot of people being impacted, and he's absolutely right. Compassion is the word here. Coming from a law enforcement background, I'm fortunate enough to have been now working with people in the public health realm and have a different perspective on the implications of substance use disorder than I had 5 years ago when I started this program. So this has been a great opportunity. Next slide, Amanda. What we'd like to do is the outline of what we'd like to talk about is talk about the HIDTA program. District Attorney gave a pretty good overview, but I'll touch on a couple of other components to it, and then we'll talk about the overdose response strategy specifically, which is what Amanda and I work on, our roles, and a little bit about what's going on in Massachusetts currently and nationwide, and the overdose response strategy projects that we work on. So and try to find, as you listen to to our outline and some of the things we talk about that we do, maybe there's places where we can work with you all and collaborate, and try to continue to have a positive impact. We've been working with the people at Plymouth County Outreach, almost since the beginning, and it's great that you've adopted their model. We think it's a pretty successful model. It's now being kind of checked for efficacy, an efficacy check, just so we can put a good seal of approval on it. But that takes a little bit of time. But it seems to be a very worthwhile program and has a great impact. It did down in Plymouth County, I know for sure, on a number of different levels. So next slide, please. So HIDTA, High Intensity Drug Trafficking Area, is a program that was created by Congress, as the DA mentioned, in the Anti-Drug Abuse Act in 1988. So the interesting word to pick up on here is program. we're not an agency. So we're not like the DEA, the FBI, the ATF. We're not a federal agency. We don't have any powers of arrest. We can't, we don't carry any badges or guns, anything like that. We're a program that works under the Office of the National Drug Control Policy. So the ONDCP, the Office of National Drug Control Policy, is actually situated right in the White House. They're the policy arm of the president to help advise him on drug issues. You've probably heard of the drug czar, and that's our ultimate kind of boss, if you will. And so the ONDCP provides resources to the HIDTAs. And, when HIDTAs were created in 1988, their basic role, the goal of HIDTA is to disrupt the market of illegal drugs. Okay, that's their basic role, is a resource for law enforcement to work on illicit narcotics and interrupting the influx of illicit narcotics into the country. So that's their basic goal. That goal has expanded. The mission has expanded greatly over the course of the last 5 to 7 years, where a program like ours, that we'll go into a little more detail about, is part of HIDTA, to incorporate public health, public safety component as a different way to interrupt the drug markets. As a way to work more cohesively across a lot of different disciplines, as opposed to just law enforcement. And what HIDTA does is HIDTA provides resources, a lot of different types of resources. Sometimes it's monetary resources, but sometimes it's intelligence resources and things like that, to both law enforcement and public health agencies and entities in different ways. So we're exploring a lot of different ways to try to work on this problem. And we think we've been successful in a lot of these areas as well. So, the basic component about what HIDTA is, and it's just 29 nationwide. It's a nationwide program. I'll show you a map in a second of where New England is. And so the thing is that we bring the ability to bring information from across the country. What's happening in other parts of the country often impact what happens in New England. And so, it's important to try to have that cross region discussion because the drug market is so fluid these days. Next slide, please. This is a map of where we cover in New England, where the HIDTAs are nationally. And then if you give another click, this is where we are in New England. You'll notice that it's broken out by counties. So the way the federal government lays this program out is that you need to get county approval to become a HIDTA county. And it's a pretty lengthy application process. It's very involved. You have to kind of prove to the powers that be in Washington that there's a need for federal resources in each county, in the particular county, in order to supplement what's already going on, by the local authorities, state law authorities, and to try to and how those resources would be used to, accomplish our goal of reducing, the illicit drug market in these areas. Currently, Berkshire County is in the process of applying for HIDTA designation, and I think Franklin County is exploring that option as well. So you can see that if you look at that map a little bit, you'll see that it kind of follows a lot of the highway routes, because we know from our experience, and you probably know it as well, is that a lot of times the illicit flow of narcotics follows the nation's highways. So, that kind of makes sense. So next slide, please. New England HIDTA specifically. New England HIDTA covers all 6 New England states. We sponsor a number of different issues. As I mentioned, New England HIDTA provides resources in different ways. So we sponsor task forces throughout New England, 18 of them currently. There is at least one working in Worcester County. We sponsor, support the Domestic Highway Enforcement Program. And that's a nationwide program through HIDTA, where law enforcement officers who are doing highway enforcement, report about their interdiction efforts and get specially trained in interdiction efforts on the highways. A lot of our narcotics are moving on our nation's highways. And so to try to track that and keep track of it and use that intelligence to intercept other shipments of narcotics is important. And we will regularly get reports from people out in the Midwest, law enforcement officers through the Domestic Highway Enforcement Program, stopping and arresting people from our region, from Massachusetts and New England in general, transporting back from the western part of the country large quantities of marijuana, for example. That's a current big issue that we run into all the time, where people will go out to California or Colorado, Washington, and load up their vehicle or get a rental car and load it up and bring back hundreds of pounds of marijuana to our region, which causes us a lot of consternation. So, it's a great program that allows a free flow of information. Deconfliction is a law enforcement tool that's used for law enforcement to make sure that we don't have multiple agencies doing investigations, overlapping investigations on the same people or the same places. So, that's a tool that we offer as a free resource to law enforcement. The overdose response strategy program we work on, we'll go into a little more detail on that in the future. And training, we offer training not only to law enforcement, but to a lot of different entities through our program. As I say, we've expanded our program out in the last 5-7 years, so that we work with the Boston University and Boston University Medical Center and provide what's called the scope of pain, safe prescribing practices. It's a training for doctors and nurses on safe prescribing of opiates. And so if you think back to 5 or 6 years ago, when our opioid problem was in its early stages and being identified, as we know now, a lot of that came from, some prescribing issues in the medical field of opiate drugs. The doctors and nurses were misled somewhat as to the potential for addiction. And, through BU, we sponsor some training for them on safe and competent prescribing practices. And, it's a funny story. When it was first, Jay Fallon, the director of New England, will tell you the story, is that when he first got involved in that, they went to a training of doctors and nurses, and, were trying to working with the BU doctors to talk to this group. And basically, they weren't well received, by the doctors and nurses. Who are you from law enforcement to tell us how to prescribe? And fortunately, good for the director to realize they were absolutely right. It's not for us to tell them how to prescribe. So the doctors do the training. It's doctor to doctor training, and HIDTA just sponsors the training. And it's been well received, and has been going on now for quite a while, 7-8 years. The ISC, the Investigative Support Center, is co-sponsored by the Mass State Police and the Federal Bureau of Investigation. And we have a number of analysts at the Commonwealth Fusion Center here in Massachusetts. And what they offer is free analysis opportunities for law enforcement throughout the Commonwealth, and not just in the states that are HIDTA, not just in the counties that are HIDTA counties, but for anybody. And so if, some of your, law enforcement entities in Worcester County are doing an investigation that involves narcotics, our analysts are available to help them in a number of different ways. Link charts, social media exploration on some of the people that they're investigating, helping with phone taps, things like that. So, it's a free resource provided by HIDTA, and a lot of agencies take advantage of it. Smaller agencies. I was a chief in a small agency. I couldn't afford an analyst in my agency, and I'm sure a lot of the chiefs on the call are in the same position. But now you've got access to analysts that are available to you, and nobody has to worry about us stealing their cases, because we can't make arrests anymore. We're just here to support your efforts. So. We put out a lot of intelligence bulletins. In our ISC, we have representatives from the DEA, the IRS, Homeland Security, Customs Border Protection, Mass National Guard. So we've got a wide view of what's going on with all those people, and have some great contacts in those agencies, which helps with information flow, which is key to all of this, is information flow. So with that, I'll turn it over to Amanda, and she'll talk about the ORS program in more detail.
Thanks, Jim. So just to start off about the scope and reach of the ORS program. So the ORS is implemented using state teams that comprise of a drug intelligence officer and a public health analyst like Jim and I. Currently, there's a DIO and PHA in 30 states, which covers 21 HIDTAs. And we have a DIO in all 50 states, and the goal is to have a PHA in all 50 states, hopefully by the end of the year. So we're still growing, but we still have a really, really great reach as of today. So just kind of starting at the most basic level, what is the overdose response strategy? At its core, it's a unique public health and public safety partnership that was created to help local communities reduce overdoses by sharing timely data, different intelligence bulletins, like Jim was saying, and sharing different innovative and evidence-based strategies to help with their work. The ORS allows us to collaborate across sectors. So having this public health and public safety partnership allows us to have more timely data, more efficient data, better partnerships, reduce redundancies. And I think the list goes on how strong and the possibilities for this partnership can be. It allows us to share data, insights, and trends. So this allows us to kind of build on the evidence, allows us to share kind of what's working, what's not working, both within the state and across the nation. It allows us to inform and help local communities build and develop local solutions to reduce overdoses and save lives. So through that evidence base, through that data sharing, and through the collaboration, it allows us to make better decisions on where we can make the greatest impact and, all reach our goals of reducing overdoses and saving the lives of those in our communities. So more specifically, the program goals. So these goals are what drive Jim and I, so the public health analysts and the drug intelligence officers' priorities are kind of guided by these goals, starting with sharing data to inform rapid and effective community overdose prevention efforts. 2, by supporting immediate evidence-based response efforts that can directly reduce, overdose deaths. And design, new and promising strategies that are at the intersection of public health and public safety. We know that there's not always going to be, a strong evidence base for all strategies. So by designing and using these new strategies to help build that evidence base is a really important goal within the ORS. And finally, primary prevention efforts, using effective and efficient primary prevention. So we start the problem before it starts, reducing substance use in general and overdoses over the long term. So a little bit about my role as the public health analyst. My goal is really to serve as a public health resource to both our public safety and our public health partners. I want to help enhance the data collection and sharing between all of our partners. And I want to help build, local partnerships so we can do some of these great programs to help prevent overdoses. Some of the things I'm responsible for, as you can see, integrating public health and public safety data, coming up with different reports and bulletins and trends that can be shared across sectors is really important. Enhancing the surveillance so we know exactly what's going on and how we can best address it, and helping develop overdose response protocols, both evidence-based and those new and emerging, public health and public safety partnerships that can be used to reduce overdose.
So in my role, and I'll just make a comment too about Amanda's role, if you give me a second. Just an example of one of the things that Amanda would have worked on and that we worked on together recently was, as COVID hit, there were a lot of questions, and I'm sure you all had similar questions about what the impacts of COVID were going to have on the overdoses. Not only we get the question not only statewide but nationally. People at ONDCP wanted to know what we were all seeing, and they use us as a resource to try to gauge these things. So we were watching very carefully and tracking very closely during, April, May, and June, what was happening with our drug supply and what was happening with the, with the overdose situation. Were we seeing increases? In some states, we're seeing, pretty marked increases. Fortunately, in Massachusetts, we didn't see a great increase in overdose deaths. There was a slight increase in May, but generally, the numbers came right back into line with where they were the previous year. And they've kind of stayed pretty consistent throughout the rest of the year for us, which is not, it's on one hand, it's relatively good news because we haven't seen a big increase, but on the other hand, we're still losing people to the rate of about 2,000 people a year in Massachusetts. So, but that's just an example of some of the things that we would work on and how, we're kind of nimble where as the COVID hit, we were adapting to what the current situation was and trying to gather data and keep it current. When we started this program 5 years ago, we were looking at overdose data that was 3-4 years old. If you remember, if you go back to 2015, 2016, the only overdose data we had to use was coming at a national level, and it was from 2012, 2013, 2014, which, the drug climate had changed significantly in those 3 or 4 years. So trying to get current information is really important, and ODMAP is a big component of that. And the SIM system that you all are working with right now, we're very familiar with. We know the people at Kelly Research Associates very well. We work with them. I've been working with them for years. And that'll help you to keep current data by using their system, which is another good tool, a great tool. So in my role as the drug intelligence officer, what I do is, pre-COVID, I would go out, I'd be on the road 3 or 4 days a week, meeting with law enforcement at where they work. I'd go to detectives meetings, regional detectives meetings, mass chiefs of police meetings. I'd be at regional law enforcement organizations meeting like NEMLEC and the Worcester, County chiefs of police meetings, stuff like that. Wherever I could get my foot in the door and go in and talk about the program a little bit. That's how the program started. And it's important to keep those relationships. Unfortunately, with COVID, it's a little more difficult to do, but in the future, we'll be back at that. But through those efforts, I was able to gather a great distribution list of information of people across the state that work in this field in law enforcement. And what I do is I track felony drug arrests and share that information. So if somebody from outside of Worcester County was arrested on a drug charge, I would notify the local police department in Worcester County about their resident that got arrested, and notify the task forces that work in that region. So, there'd be an understanding, that somebody is involved in illicit narcotics, and they may or may not be aware of it, but now they'd be aware of it and be able to at least have that person kind of on their radar screen and see if they can offer them some resources or see if they can help them out in any way possible. So, facilitate information sharing that way. That exact same job that I'm doing is being done across the country now. So as people in law enforcement are doing investigation across state lines, I can be a resource to help make connections in those states where you don't have to make cold calls to a PD to do, to try to get somebody to work with. We've got relationships, and that's what's important in all of this is relationships, both in the public safety side and the public health side. And that's what we try to do, is create those relationships and use them, to everybody's advantage. So that's the basic role of the drug intelligence officer, is to work with law enforcement and try to educate law enforcement about how public health works. I've learned a lot in the last 5 years about public health, about harm reduction, about medication-assisted treatment, about the opportunities for syringe exchange programs and how they impact substance use disorder, all those different things. So, we use these opportunities to talk to our partners in law enforcement and help to educate them about what's going on the public health side of the house. And look, everybody being better educated about what the other people are trying to do only works to everybody's benefit. So That's a lot of what I do. The next slide, please. On this slide, this is a some current trends here in Massachusetts, and if you see this is the number of overdose-related deaths, opioid-related deaths across the state of Massachusetts from 2014, I'm sorry, up until third quarter of 2020. And you'll see that blue line at the top is fentanyl. And you can see if you go back down to 2014, where it started relatively low in 2014, is now the #1 contributor to overdose-related deaths in Massachusetts. It's in about involved in about 93%, 94% of substance use disorder-related deaths. What we're seeing, and it's funny that District Attorney mentioned cocaine. If you follow that third quarter and come down, the purple line, which is the next most prevalent drug in overdose-related deaths, is cocaine. So, what we're seeing though, and what's important to note here, is a lot of polysubstance deaths. So it's, even though fentanyl is mostly the one that's responsible for the death because it shuts down the respiratory system, there are other drugs often involved in the system at the time of death. So we're seeing a lot of polysubstance use. And you can see from the lines here what's involved: benzodiazepines, the next one down the list there, and no, they're not straight cocaine. Sorry, there's a question in the thing. Not necessarily. They're usually involved with some other drug, and a lot of times it's fentanyl. The question asked about whether cocaine deaths are straight cocaine, and no, that's not generally the case. A great majority of these deaths, as I was just mentioning, are polysubstance deaths. And I think that's where we are today. The drug scene changes regularly, and polysubstances seems to be the current kind of one of the current trends, and it's really troubling. Causes, so next slide, please. Our emerging threats in our region. So in Massachusetts, our emerging threats are counterfeit pills and methamphetamine. For many years, we heard about the comings of methamphetamines. I've been in law enforcement for a long time. And, years ago, they would say meth's coming, but it never really made it across the Mississippi. When we were waiting for it. It was big out in the western part of the country, in the Midwest, but never really came here. But I'm telling you now that it is in our region. It's here, and it's becoming a growing concern. We see the increase in seizures. I talk to law enforcement officials regularly, and they're telling me they're coming across it more and more often. It's always been a little subculture thing, a niche drug in this region, in the gay subculture and in the motorcycle gang subculture. But now we're seeing it much more in mainstream substance use. And there's a couple of reasons for that. The drug cartels down in Mexico are producing methamphetamine in significant quantities. They're making it, literally by the ton, and shipping it through their traditional trafficking routes into our region. And there seems to be an appetite for it. Some of the research that we've been kind of seeing and hearing about is that people have an opportunity to try it and go to it because they're afraid of fentanyl. They're seeing how many people are dying from fentanyl, and this is an alternative, even though it's a stimulant as opposed to the opioids, which are not stimulants. But it seems to be an attractive option, which is kind of concerning. So we did some training. Amanda and I were able to coordinate some training with Justin Alves out of the Boston Medical Center recently for law enforcement and public health. And we hope to have him do some more about methamphetamine psychoses, and how to respond to people that are having a meth overdose type of situation. Nationwide, we're seeing a lot, an increase in isotonitazine, xylazine, ketamine. And I just sent out a bulletin yesterday. I just saw a bulletin yesterday talking about parafluorofentanyl and bromphene, which are two more synthetic opioids that are on the rise nationwide. So, those are all areas that we see emerging threats. But the counterfeit pill thing is something that everybody should be aware of. For anybody that's buying pills on the street, they're taking a huge chance. We're seeing these counterfeit pills. Many times they contain fentanyl, but even seeing them now that are made with methamphetamines. So you really don't know, anybody buying pills on the street don't know what they're getting, and they're taking a huge risk. So next slide, please. And I'll turn it over to Amanda.
Thanks, Jim. So just to talk about some of the projects that Jim and I work on or have worked on in the past. So cornerstone projects, I forgot to mention that my role is also supported by the CDC. So these cornerstone projects are projects developed by the CDC to build evidence base, to learn about, new emerging trends or different promising practices, to try to get a nationwide view. So through these cornerstones, they try to leverage the DIO and public health analysts network throughout the state to kind of learn more about, what's going on, and kind of get a snapshot from across the country, kind of what's going on. Some of the past projects have included law enforcement's knowledge on the 911 Good Samaritan laws. They've done fentanyl. They did overdose education and naloxone distribution in jails, just to kind of get an idea of kind of what's going on and maybe give some recommendations on what the next step would be or next best practice would be. And I've included a bunch of links on here. So when you guys get the slides, feel free to click on them. So for the cornerstone projects, there's a report that you guys can read if you're interested in any of kind of the findings from each of these projects. The next two bullets are two grant opportunities that are given through the ORS and HIDTA. So the community level intervention initiative, or the Coakley grant, is actually funded by ONDCP. This year they funded the University of Baltimore to fund, I think it was like 8 programs across the nation that are at the intersection of public health and public safety that are using evidence-based strategies. This year, they funded actually 2 programs that were here in Massachusetts. One between the partnership of Brandeis University and Perry, which is the police-assisted addiction recovery initiative. And I don't know if you guys heard, their pilot project that was police-led, giving out fentanyl test strips and trying to connect people with care and different resources. So that through this grant, they're going to expand that project, which is awesome. And then another program that was funded was through the Health Resource Information in Action. They have a Wheels for Hope, which addresses the barrier of transportation. So anyone who has a substance use disorder and needs transportation to any of their appointments can call them and they'll give them a ride to and from their appointment, which is really great to try to break down some of those barriers to treatment. The next grant program is the pilot projects, and this is funded through the CDC and NACHA. And this is a really great opportunity to work with both Jim and I. We have a really big role in this. And this is really great if you guys have an idea for maybe a project that is not fully evidence-based yet, but it's new and it intercepts between public health and public safety. So it's a really great opportunity. They do both planning grants and implementation grants. And it's a really great way, say you have a program and you need an evaluation, you get the support from both myself and the CDC. So I'd really recommend you guys looking at both of these grants because they're really great opportunities. I've included both of the links so you can get an idea of what the RFAs look like. There is a really quick turnaround time. So I'm trying to urge people to look at them, sooner rather than later. And, we can always have a conversation if you have an idea. I'd love to hear about it. Jim kind of mentioned ODMAP, which is an online application that maps the different overdoses in the area. This is a really great tool to help target outreach efforts. You can see where the most people are overdosing in your area. You can either do mobile outreach or post-overdose outreach, however you want to use it. A really great feature of ODMAP is they have an API. So I know Plymouth County just did their an API through their SIMs to OD map, and all of the stuff automatically goes there. And their public health and public safety partners can go and look and see kind of where the overdoses are happening and maybe where they can target some outreach efforts. So also we do different trainings, bulletins, and reports. As Jim had mentioned, we did a really awesome methamphetamine training and some bulletins that we put out, developing different reports. So that's been a really great success for us. And kind of like Jim mentioned, we worked with Plymouth County Outreach with some of their outreach efforts, and a new project that Jim and I have been working on is the Massachusetts Drug Supply Data Stream, which is essentially a surveillance system of kind of like the drug supply of different testing. And this is done with Dr. Green out of Brandeis University. It's another up and coming project that's really interesting, and I would definitely keep an eye out for it. And this is not all inclusive. This is just to kind of give you some ideas of some of the projects we've worked on. And finally, I just wanted to end with a few resources for you guys to take a look at, starting with our website. If you want to learn more, or you have a friend in a different state that you want to connect with, the other overdose response strategy team, all of the contact information will be up there in different reports, and you can kind of see what we're all up to. Shatterproof, they have a really awesome website called Atlas. It's very similar to the Mass Substance Use Helpline. And you can find quality care. You can compare different things. So it's a really great tool if you guys have a client or if you're working with a person that needs care and you don't know where to go, you can go to Atlas and it'll give you all the options similar to the helpline. Health Resources in Action. If you guys are looking for any kind of training or any kind of resources, it's a really great tool based here in Massachusetts. I believe they're funded by DPH. I've attended a bunch of their trainings and I find them super helpful. The Boston Medical Center office-based addiction treatment training and technical assistance. That's a mouthful, but this is who we partnered with for the meth trainings that we provided to both our public health and public safety partners. And they also offer different training opportunities and different resources. I know we even watched a training on harm reduction. So if you guys are looking for anything, this is also a really great source. And then PARI, the Police Assisted Addiction and Recovery Initiative. I know you guys are doing some really great post-overdose outreach work. They have some great resources, both through their AmeriCorps program that help police get a recovery coach and just different evidence-based strategies that they've seen work. So I would highly recommend, taking a look at these resources. And of course, please use Jim and I as another resource. Here's our contact information. And if you guys have any questions, please feel free to reach out or ask us now. And I just want to say thank you guys for allowing us to speak today.
Thank you, Jim and Amanda. Just a question on those resources. These are type of things that are available to everyone, or is it just law enforcement?
Nope, they're available to everyone.
In the Boston Medical Center office-based addiction treatment, training and technical assistance, is that through a particular hospital or is it just an organization?
So it is through Boston Medical Center, but it is available throughout. They have a grant and they cover all of Massachusetts. I know they've done trainings for both public health and public safety.
Okay. And out of all of these trainings and everything, I know that we try and share best ideas. Were there any that jumped out at you as just being outstanding? If someone had to pick one training, I guess is what I'm looking for with that.
Okay.
Without you putting anyone down. But is there something that you just walked out there and said, wow, the wow factor?
Yeah, I think it really depends on what you're looking for. I will highly recommend Boston Medical Center and the methamphetamine training that Justin gave for us. We always get great feedback. He's an excellent speaker. If you guys are looking for more of, what what's MAT, or, what's some overdose, how to prevent overdose, maybe at that level. The Health Resource in Action is a really great resource. They're more opioid focused. So I think it depends on kind of which area you're looking to kind of get training.
Okay, so the Health Sources in Action is a great resource for opioids.
Mm-hmm.
Okay. Well, Jim and Amanda, I just want to thank you. Oftentimes we hear about acronyms for organizations and we don't understand too much about the organizations. But Jim, all of that discussion as well with, crossing the boundaries. The problems don't begin and end at our boundaries. And the role of law enforcement has changed so much. And I was glad to hear you mention compassion. But you're not talking about compassion with high-level dealers and drug traffickers.
No.
In neither way, not the people bringing the poison in. And also, deconfliction was something that I learned when I took this job. As they said, you don't want to have two organizations drop down on each other in a certain area because they're both looking at the bad guys and all of a sudden drawing guns on each other. But especially with regards to the crossing the borders, and thank you guys for making us, getting us smart on everything that you do. We're just involved with the task force, and you almost take for granted the role of law enforcement with the heavy duty dealers, but it is compassion, and it is removing stigma, and we're all on the same page when it comes to that and beating this horrible disease. I can't thank you guys enough for being here. I appreciate. Liz, are we taping everything today?
We are taping everything today, but I'm going to confess right here, DA, in front of everybody, that I started recording just a little late, but I did get all of Amanda and Jim's session.
Yeah.
Unfortunately, I got your fabulous opening remarks, did not make it in, but.
Well, that's okay.
Jim and Amanda, well, I know Jim answered this question, but I think it's a really good question for the group. Someone had asked regarding the cocaine overdoses, was it just straight cocaine or was it a polysub overdose? And I thought that was a great question, and I know it was answered through the chat, but if you could just kind of give that answer to the group, that would be fantastic.
Do you want to go? Yeah, so if you look at the cocaine deaths, the Mass DPH put out this really awesome report that I would suggest you guys check out about stimulants. And they found that of the cocaine deaths, I believe it was around 80% also included an opioid. So majority of the cocaine related deaths also have another substance.
Oh.
Great, that makes sense. And just so you guys know, I've been taking a lot of notes about your trainings and everything, so you're definitely going to hear from me after this.
Yes, please. We'd love to give them.
So now,
Yeah.
I know people signed up for a breakout room, and so what I'm going to do now is I'm going to open those rooms, and your screen will automatically go into the breakout room. There's going to be a moderator in every room from the DA's office with some talking points. If you're in room 4, you'll have a chance to ask Jim and Amanda some questions as well, and the DA will be in there as well. So when I hit this button, if you've already been assigned, you should just go into your rooms. The rooms are going to last about 30 minutes. And there'll be specific talking points, and we're kind of trying to get some networking going and also getting more feedback for the year. If you came in late and I didn't assign you, you'll still be here, and it'll just take me a second to assign you to the room. So is everybody ready? This is.
Yeah, hold on, Liz. And I know some people have time constraints and some people will be dropping out. And I just want to thank you all for keeping your foot on the pedal with regards to this. We all have our different reasons. We all have our different passions. But we certainly do share a passion for trying to make it better for people and make families who are suffering suffer less. So I want to thank you with regards to all of that. And thank you. And as we go to the breakout rooms, I know we can all get smarter. We can always get better. It's something my dad always told me. You can always get better, Joey. You can always make it better. So thanks for being here today, and look forward to the rooms.
Great. All right. So here we go. I'm going to open the rooms. Let's see. It's a little Star Trek-y here. Don't you think? Oh, there we go. Oh, DA, you should be in a room. Oh, okay. So if you're still here, Jen, I thought I put you in a room too. What room did you want to go into? I'm sorry. I swear.
You throw me in the room, Liz, I'm going to get a cup of coffee.
Sure, and then I'm going to assign you to room 4. Absolutely.
Assign to room 4.
Ryan Pearlie and Dr. McCartney, can you just let me know what rooms you want me to send you to? Okay.
John Zenos is making a good presentation.
Liz, in fairness with Brian, I think he's also trying to cover stuff in court too.
I think he got the late email.
Virtually,
that's
he
fine.
did,
That's
and
fine.
joined it because of the
Okay,
email.
DA, after you get your coffee, I'm going to put you in room 4.
Okay,
And Dawn, whatever you want. If you don't want to go in a room, I'm going to kind of jump from room to room just to make sure everything's going okay. So this part of it might be a little funny when we.
I think Donnie's busy. Why don't we give him a break?
Okay,
He's
Thank
going to juggle district court. Thanks, Liz.
I can make you guys disappear. Isn't
Liz,
that
nice
good?
job.
Hey, Liz,
Yeah,
if you can,
Don't
Mike is
go in-
open.
I'll go in room 4. I got to get to the DA's meeting. You want to just make me disappear? Or
Sure,
you
I'm
want me
going to assign you to room 4 right now, DA. Do you mind?
No.
And then, and Eileen is taking the, let's see. Hold on, it's not letting me.
Okay,
Liz,
I'll get my coffee.
if it doesn't work, the DA has his DA's association meeting, and DA, your mic is wide open, just so you know when you leave here, unless you
Okay,
mute it.
yes, yeah. You know, Liz, if it's okay, I just assume just go to the DA's meeting.
Okay, I'll let them know that then. Okay, that you, I'm just gonna say you got called out. That's fine, because I know you need to get to that too. So perfect.
Well, what is the meeting in group 4?
That's the
That's
HIDTA
the
group is
emerging
talking about emerging trends.
All right, I'll go there for a little bit. I'll go there for a few minutes. Thanks.
Okay, I'm gonna try to assign you there now.
And Donnie, thanks for the mic drop.
Thank you.
Assign to, oh, we'll wait until he comes back before I assign him. Hopefully I can edit this part out.
No, Liz, good job. Honestly, nice job.
Yeah, it went well. It went well. We had a little technical glitch, but I think it went great. So, oh, and Brian left. That's fine.
That's fine.
So,
No,
yeah.
it was
And then
nice that he
people are
joined.
going to come back and do quick report outs. And if the DA's gone, we'll just close it up from there.
Okay, if you need me to do something, let me know. And if not, I'm just gonna basically shut off my video, shut off my phone, my mute, and just, so would I just be back in the whole group when everyone comes in that way?
Yeah, you won't go. If you shut off your video and your audio, you won't go anywhere. When everybody comes back, you'll just be right here. So
And that's what I'll do when I'll do some stuff around here.
that's perfect.
And
And
if someone needs me, I can text you when I'm still hooked in. Thank you.
yes, exactly. And I can handle the closing of the meeting if the DA needs to go.
Perfect. Thanks, Liz.
Okay.
Thank
Thanks,
you.
Dawn.
Nice job.
Oh, thanks. We might have lost a few people along the way as well. I know a lot of people left at different times, so. Okay.
Yeah, give it a sec. So the breakout rooms are just ending, so I might see a few more.
That's what I'm saying, breakout rooms. All right. Okay. Yeah, it looks like we are down a few participants too. So just really briefly, if one person from each room wants to just give a really, really quick synopsis of what you talked about, and then everybody, every room had somebody from the DA's office. They're going to give me the detailed notes, and that'll be sort of part of the follow-up to the meeting. So I'm just going to go with breakout room 1.
Yeah, Liz, I was moderating for that group, but I said I would give the breakout of what we talked about here. So we were talking about messaging and planning for 2021. An important thing I think we talked about was timely messages and trying to make sure that whatever we're putting out makes sense for the time frame that we're in. They did a good job of that around the holidays with the the flyer that was created, we shared throughout the month, but I think we want to continue doing that type of thing. We talked about messaging around COVID in particular, with increased substance use and isolation causing mental health problems. I think another thing that we talked about was a possible forum or something addressing the idea of social norms around drug use or substance use in general. It's one of the things that this group's been looking to address with virtual messaging as well. But an important topic, you know, trying to help people understand how their normalization of substance use affects kids, affects people in recovery, everything along those lines. And another topic we talked about was mental health and coping skills. That might be something we could do with our virtual messaging or possibly some type of forum. And then the last thing we talked about was possibly creating a Facebook group for the OTF and encouraging members to have a little bit more back and forth participation as an entire task force group. That way it wouldn't be kept just to these meetings, but it'd be something we could do more regularly. So
That's great. Oh, wow, you guys were really busy. Room 2.
Hi, so we had community collaborations. It was just Nika and I, so we had a really good discussion. Nika, if I missed something, please feel free to jump in. So ours is really involved. We're talking about widening the sphere of influence in making collaboration and recovery support a priority. So we were kind of focusing on different businesses, and Nika had mentioned there's a bank that will work with people in recovery. So when those paychecks start hitting, they have somebody to kind of guide them through the process, make sure that there's checks and balances in place so that they might not fall back into that cycle of substance use. And if we can tap into things that are already working, where businesses are already showing their support to recovery services, tap into those leaders and have them kind of branch out, make connections with maybe banks in the town over. And we talked about banks specifically because of Nika's knowledge of this specific bank and what's working, and how do we take the things that are already working in communities and get them to churches and faith-based groups, and again, businesses, people that are coming out of the jail system or maybe have an arrest, finding out what steps and supports are already in place and making those more widely available to the folks that would need them. Not necessarily recreating the wheel, just taking what's already been working for people and getting that information out to others. So basically, tapping into the leaders, what's working, and how do we get that message? That's going to be the tough part, is getting the people on board to just hear the talk, jump on a Zoom meeting, talk about what we know is working and how we can roll it out to the different areas in our community. I know I missed some stuff, Nika. Feel free to
Well, we have the detailed notes, so I know it's in there. There's some detailed notes, so and that'll go out in detailed in a follow-up too. So, and a lot of good ideas. And I mean, I had the opportunity to sit in all the groups and hear some great ideas. So, room 3. Scott Pelletier, go ahead. Be the speaker for your room. I know you can do it.
Oh, thanks. Great. All right. So I've been involved with that group for a while now. So we're discussing stuff that's happening, and what we've been going for. But mainly what we talked about is different electronic databases about what we can utilize that's already out there, like the community net on Bertha website. And then talking about different ways to communicate and limitations that the town, the state, and the cities have because of cyber safety issues that they have. So one of the groups I'm in with the Central Massachusetts Addiction and Professionals Network that we do, we're setting up a LinkedIn page to help each other out for instant communication if people have beds or need help, or just update what their services are. Things like that, I think we were talking about. Anything you want to add, Kat?
No, I think that covered it. That basically we're one centralized database that we all own responsibility for our own details.
Yeah.
Yeah.
Right, and we've been talking about that for a while and working on it, and I think we're just gonna, this group has been pretty dedicated, so we should have more information on that, I'm hoping, soon. And then I'm gonna do room 4, I know was emerging trends and was a little follow-up to what we talked about, what Amanda and Jim talked about. But when I popped in, you were talking, I heard some discussion of difficulty with getting treatment because of COVID, and maybe a quick update on that, because that would be good, I think, for people to know.
We talked about how COVID had increased the effects at all the rehab centers along in the problems. But I don't know, does David want to talk a little bit more about the COVID issue?
Yeah, David, if you could mention that, and Jim, if
Yeah.
you could mention that prevention thing.
And then
Yeah.
prevention, we talked about prevention a lot.
Yeah, I can speak to that. Unfortunately, I don't think anybody's surprised that COVID, we were really good. We lasted for a real long time, but COVID has impacted, for those of you that are trying to place clients, several of the detoxes and rehab programs recently have now been impacted by COVID causing some of the ATSs and CSS resis to actually close units down because of either clients testing positive or even in some cases the staff now testing positive. So I think that's something to be concerned about, where it's a double-edged sword. Not only are you having difficulties in going to a lot of these detox 3.7s and Resi 3.3, 3.5 programs, but as we all know that due to COVID, the general acute care hospitals aren't taking clients in for substance use because they're using them for COVID patients. So just it's more of an FYI that, I work at Spectrum in the recovery center. We've been recently impacted. I know RCA is going through it right now. And a couple of weeks ago, it was also Washburn. So, I just think people need to be concerned. I don't think, at least immediately, things are going to get better. I think it's going to be continuing going down that trend. So it's just an FYI, and it's unfortunately, it's a bad trend.
Yeah, and the DA wanted me to just mention about a program that we talked about called ADAPT, ADAPT. I put the acronym in the chat box with the link for the website. So that's a HIDTA program out of the Washington Baltimore HIDTA, and what they do is they focus on providing training and technical assistance for resources for prevention efforts, evidence-based prevention efforts. So if you're working in an area trying to provide evidence-based prevention efforts, ADAPT could be a good resource for you. And, Amanda and I would be happy to try to make a link if that would be helpful for anybody. So feel free to take a look at that website, see if it's something that might be of use for you, and utilize us as a conduit to get in touch with them.
Thanks, Jim. That really is our bread and butter. We do a big, can't thank you enough. Got so much out of this meeting today. That's whipped cream on top of the ice cream. Or gravy, whatever you want to call it. Thank you.
Amanda and Jim, I'm probably going to follow up with you on some of that stuff too, because I'd like to put a little something together that can go out to folks too in a follow-up. So we have one last thing to do, DA. That's the poll. If everybody wants to take my poll, my fun poll, it's quick. It's only 3 questions. So let's see. I'm going to launch that poll right now. maybe everybody's. I'm going to end it. I think a couple of people are not participating right now, so I'm going to end it. And I am going to share the results. So, okay, we have some great resources here to look at. Stigma still, virtual meetings and virtual trainings and virtual messaging. So it's funny, I thought more people were going to say no virtual gatherings after this, but I think that people have enjoyed it. And I think it's been a great way to get some messages out. So it seems great. A lot of all of the above. Well, this is really good information for me as well as we move forward in how people want to operate. So I think that's all I have, DA. I plan on really putting something together. It might not go out tomorrow in tomorrow's opioid task force email, but it'll definitely go out in next week's. And I'm going to follow up with other subcommittees too to get a meeting going in February. So that's all I have, DA.
Okay. Yeah. Thanks everybody for being here. Jim and Amanda, thank you so much for bringing your expertise and friendship here. And guys, best wishes in this fight. Let's keep our foot on the pedal. And Liz, thank you so much. I know this is a pain in the ass putting this together.
No, it's not.
Great office. I got a great staff.
It gives me great joy to put this meeting together, DA. Don't ever say that. This is
all right.
This is my
yeah, and to you,
thanks everybody.
Phil, Amanda, Lindsay, Eileen from our office, Kevin, Donnie Zenos, thanks everybody.
Thanks.
And well, thank you guys. Take care.
Thank you, everyone.
Bye-bye.
Thank you all.
Bye-bye.
Bye.
Hey, hi. I'm
Is
just
everyone-
I'd like to go.
Are you
through-
sure it's safe that everyone's gone?
Well, just Dawn's here. As far as I know,
Okay.
it's just the three of us. Yeah.
Okay.
I'd like to usually go through the chat to see if I can pick anything up. I don't think that Jim put that ADAP in the chat, but I actually know what that is. I wouldn't.
Right,
say
and
that.
then, yeah, so,
But I'm
but
gonna
that's,
get
I
the
just
notes
didn't
from
see
everybody.
it.
Yeah, I think there was a lot of, I thought that went pretty well.
Honestly, it went excellent.
So I tried to wait till the last minute to pre-populate my Zoom rooms, right? And then it wouldn't work because there's this thing that happens with Zoom rooms that like only one time you can populate. And then after that, it wants you to export the list as opposed to it. But then when I opened it this morning, it said export. And I was like, no, I need to import. It just wouldn't do it. I was able to assign everybody, but see, you make fun of my handwritten list, but guess what? I had a list with everybody.
Yeah, you need that. I gotta pull my hair up. I can't stand it. I'm sorry.
Like, just in case, I'm gonna do it. So yeah, I thought that went really, really well. I thought it went.
Honestly, Liz, and the truth is, you're the only one that knew about populating the list.
Right, no, right. And I think
Everything else was.
And I think some people were like, why do I have to tell her that? But
Yeah.
the truth is, if you had signed in, if you had registered right when you went in at 9 o'clock, I wouldn't have your room assignment anyway, so.
To be. No, and the truth is, the breakout was okay. So at first it was literally only Lindsay,